acute coronary syndromes. It's a sort of supply-related ischemia resulting from unstable plaque. It could be anything: unstable angina, non-STEMI, or STEMI. So what do we have here? What do we have here? We have an unstable plaque, a thin fibrous cap plaque. It can rupture at any moment. It might be injured at any moment. Like at times of severe excitement, severe intense sympathetic stimulation, rapid surge flow of blood inside the coronary, this might decap or rupture this unstable plaque. And once it is ruptured, a lot of platelets will aggregate and the obstruction will increase more, unstable angina. Or maybe a little blood clot is going to form on top of the aggregating platelets and the obstruction is going to worsen and worsen, and this is going to lead to subendocardial infarction that is not sufficient to elevate the ST segment, so we get non-ST segment elevation myocardial infarction. Or maybe total complete obstruction of the coronary artery, 100% obliteration of the coronary artery, and now the whole thickness of this particular part of the cardiac muscle will die, and this will be sufficient to elevate the ST segment, the ST segment elevation MI. So the three clinical presentations of acute coronary syndromes resulting from injury to the unstable plaque are unstable angina, non-STEMI, and STEMI. And how do we diagnose it? It's always going to be the patient's history and AKG. History and AKG, the patient's story and the AKG, the patient's story and the AKG. Listen very carefully to the patient's description of his chest pain, to the patient's description of his chest pain. The patient might say, this is a new type of pain. I've never experienced such a pain. New pain. This is worst pain ever. Worst pain ever. I've never experienced such an intense pain. This pain can come on exertion like any ischemic heart disease pain, but what's unique about this acute coronary syndrome, the pain might even come at rest. What were you doing when you got the chest pain? I was doing nothing. I was just watching the TV. Or you know what? I was asleep, and this pain awakened me from asleep. I was resting, rest pain. And the most important thing, it is prolonged pain. Prolonged pain. What's the meaning of prolonged? Remember the chronic stable angina, 15 to 30 minutes, and it is relieved by rest or relieved by sublingual nitrates. This pain does not go away. This pain, acute coronary syndrome pain, does not go away. You rest, it does not go away. You take sublingual nitrates and it does not go away. It lasts for more than 30 minutes. It lasts for 1 hour, 2 hours. That's why we always advise, whenever you have a chest pain that does not go away after the first sublingual nitrates, you have to go immediately to the ER. Listen to the patient's story. Chest pain, that is new pain, worst pain, rest pain, prolonged pain, new pain, worst pain, rest pain, prolonged pain, acute coronary syndrome. Then you do an AKG. If the AKG showed ST segment elevation, your diagnosis immediately is going to be STEMI, ST segment elevation myocardial infarction. This patient is to be taken to the cath lab within 90 minutes of showing at the door of the ER, or at least give him thrombolytics within 30 minutes of showing at the door of ER. If the ST segment was not elevated, you want to do cardiac enzymes. Troponin, CKMB. If they were elevated and the ST segment is not elevated, this is non-STEMI myocardial infarction. Because what's troponin and CKMB? They are intracellular stuff. They are found inside the cardiac muscle cell. When you find them in high amounts in the blood, this means that cardiac cells are dying, and they are releasing the intracellular content of troponin and CKMB, and that's why you find them in high concentrations in the circulation. These are the AKG findings. In STEMI, you get elevated ST segment. In non-STEMI, you might get depressed ST segment. Both of them, you will have the cardiac enzymes elevated. In unstable angina, you can have a normal AKG, you can have ST segment depression, you can have T-wave inversion. These are the AKG findings in unstable angina. How to diagnose ST segment? STEMI, ST segment elevation, myocardial infarction, or non-STEMI or unstable angina, always remember, unstable angina is a history diagnosis. Unstable angina is a diagnosis by the story. Non-STEMI, you have the story and you have elevated enzymes. STEMI, you have everything. You have the story, new pain, rest pain, worse pain, prolonged pain. You have ST segment elevation and you have elevated enzymes. How to treat angina, unstable angina, or non-STEMI? Aspirin, heparin. For STEMI, you give aspirin, heparin, but more importantly, you don't give heparin, you give aspirin. More importantly, angioplasty, thrombolytics, STEMI, ST segment elevation, myocardial infarction. The most important line of management is angioplasty and thrombolytics. So, how to manage acute coronary syndromes? It's always based on the story, history and EKG. The first thing is give aspirin, orally or chewed. You have chest pain, and this is an advice even you're at home and you develop chest pain, and this chest pain, it looks worse pain, new pain, prolonged pain. Take baby aspirin sublingual. It won't hurt, but it's very, very important in lowering mortality. 25 to 50% reduction in mortality by giving aspirin in acute coronary syndrome. The most important mortality reducing agent is aspirin. And you can add clopidogrel or prasugrel. This is antiplatelets also, especially if you put a coronary stent. Nitrates and morphine, yes, they are given for acute coronary syndromes, yet they do not lower mortality. Oxygen, you only give oxygen if the patient is hypoxic. No need and no benefit from oxygen if the patient was not hypoxic. Thrombolytics and angioplasty, these are the best in lowering mortality only in STEMI, only in ST segment elevation, myocardial infarction. What's the best mortality reducing agent? Thrombolytics and angioplasty. Thrombolytics, they should be given within 30 minutes of arrival to the emergency department, 30 minutes of arrival. And within 12 hours after the development of pain. If the patient developed pain more than 12 hours ago, thrombolytics will do nothing, because this blood clot is going to be too hard for thrombolytics to dissolve. Angioplasty, this is the single best benefit. The most important benefit comes from angioplasty. Put a stent or do balloon dilatation of the coronary, or we even do a bypass surgery. And this should be done within 90 minutes of arrival at the emergency department. Beta blockers also lower mortality, but you can give them later. You can use atenolol or metoprolol. They lower mortality. ACE inhibitors, they are given to all patients, but they lower mortality only in patients with low ejection fraction. Statins also are given to all patients with acute coronary syndrome, but they lower mortality only if the LDL is elevated. So this is the full list of how we manage acute coronary syndromes. So what lowers mortality? Aspirin, thrombolytics, angioplasty, metoprolol, statins, clopidogrel. The most important thing is, the best is angioplasty. The most lowering of mortality is angioplasty and thrombolytics in STEMI. What lowers mortality in certain conditions? ACE inhibitors, if the ejection fraction is low. What does not lower mortality? Oxygen, morphine, nitrates, calcium channel blockers, lidocaine, amiodarone. They do not lower mortality, but we give them whenever indicated. Morphine and nitrates are always given in acute coronary syndrome, of course. Management of STEMI versus non-STEMI. The ST segment is elevated, angioplasty, thrombolytics. ST segment elevated, angioplasty, thrombolytics. ST segment is non-elevated. Levanox, low molecular weight heparin. Or give antiplatelets. Like agrestat antiplatelets. You can use them with angioplasty also and stenting. And these antiplatelets do not benefit STEMI.